Welcome to PMHN Podcast on Developmental Theories in Psychiatric Mental Health Nursing. This episode will summarize major developmental, psychological, and nursing theories essential to psychiatric mental health care. Covers Erikson's developmental stages, Freud's psychodynamic model, Piaget's cognitive stages, Sullivan's interpersonal theory, Maslow's hierarchy of needs, the health belief and transtheoretical models, Bandura's social learning, and core nursing frameworks by Leininger, Orem, Peplau, and Watson, highlighting their clinical relevance. To start, Dr. Lee, welcome to the show. Can you explain why human development is viewed as a continuous, dynamic process across the lifespan?
Absolutely. Human development isn't static. It's a complex journey from simple to complex forms shaped by biological, psychological, and social factors. This continuum allows clinicians to assess behaviors and learning in context, which is essential for age-appropriate care.
So, when assessing patients, understanding their developmental stage provides critical insight into their behaviors and comprehension levels. How does this framework support clinical decision-making?
By referencing developmental milestones, clinicians can differentiate between normal and atypical behaviors. For example, concrete thinking is expected in children but can signal pathology in adults, guiding targeted interventions and education.
A pivotal developmental theory is Erikson's psychosocial model. Could you walk us through its key stages and why they matter in mental health?
Erikson outlined 8 stages, each defined by a crisis or task, from trust versus mistrust in infancy to integrity versus despair in old age. Mastery at each stage fosters psychological strength, while failure can lead to issues like mistrust, identity confusion, or despair. Example: concrete thinking is normal at age 9 but pathological at age 29.
That's fascinating. How might unresolved stages manifest in clinical practice, especially in psychiatric settings?
Unresolved conflicts often show as maladaptive behaviors. For instance, an adult with intimacy issues may have struggled with earlier trust or autonomy stages, highlighting the need for tailored therapeutic approaches.
Transitioning to psychodynamic theory, Freud emphasized the unconscious mind. Can you elaborate on the core concepts and their relevance today?
Freud believed that much of our mental activity occurs unconsciously, with behaviors driven by hidden urges and conflicts. The id seeks pleasure, the ego mediates with reality, and the superego imposes moral standards. These internal struggles often surface as anxiety. Behavior is purposeful and meaningful, principle of psychic determinism. Most mental activity is unconscious. Childhood experiences shape adult personality. Psychosexual stages. Oral, anal, phallic, latency, genital failures linked to psychiatric disorders. Structures of the mind. Id. I want. Instinctual drives. Pleasure principle. Ego. I think. Rational, reality principle, defense mechanisms. Superego. I should. Conscience. Moral values. Ideals. Conflict among structures produces anxiety, leading to defense mechanism use, e.g., denial, projection, repression, rationalization, sublimation.
How do these unconscious conflicts manifest in everyday life or mental illness?
Take the example of someone forgetting a stressful appointment. Freud would call that motivated forgetting, driven by unconscious desires. In psychiatric disorders, unresolved psychosexual stages can be linked to adult dysfunction, such as difficulties with relationships or impulse control.
Given these internal conflicts, how do individuals typically cope? Let's discuss defense mechanisms, as outlined by Freud's followers.
Defense mechanisms are unconscious strategies the ego uses to manage anxiety and maintain self-esteem. Examples include denial, projection, and rationalization. They can be adaptive, like sublimation, channeling impulses into positive activities, or maladaptive when overused, as seen in neurosis.
Can you provide a real-world scenario where a defense mechanism is clearly at play?
Certainly. A healthcare worker experiencing guilt after a medical error might overcompensate by being excessively attentive to other patients. This is reaction formation, acting opposite to actual feelings to reduce internal conflict.
Shifting gears, Piaget's cognitive theory offers another lens on development. How does cognition evolve, according to his model?
Piaget proposed 4 stages, beginning with sensoromotor, where infants learn object permanence, to formal operations, where adolescents develop abstract thinking. Each stage represents a qualitative shift in how children understand and interact with their world. Piaget believes development evolves through learning and comprehension. There are 4 stages: sensory motor, birth 2, object permanence, pre-operational, 2-7, language, magical thinking, concrete operations, 7-12, logic, reversibility, conservation, formal operations, 12, Ya1, abstract logical thought.
How does this inform mental health practice, especially in assessment and client education?
It ensures interventions match cognitive abilities. For example, teaching a 7-year-old uses concrete examples, while with teens, abstract reasoning can be engaged, improving comprehension and compliance.
Let's explore Sullivan's interpersonal theory. How do relationships shape mental health across the lifespan?
Sullivan asserted that personality develops through social interactions, with specific stages like forming peer relationships in childhood and self-identity in adolescence. Disruptions in these stages can lead to anxiety or impaired social functioning, echoing in later life. Behavior arises from interpersonal dynamics. Personality is shaped by relationships, self-system. 2 drives: satisfaction, basic needs, and security, social conformity. Mental illness results when satisfaction, security needs are blocked. Anxiety directs behavior toward regaining security. Stages: infancy, late adolescence, focusing on relationships, oral gratification, peer bonding, identity formation.
How does this perspective influence modern therapy and nursing care?
It emphasizes the importance of therapeutic relationships and group interventions. For example, social skills training for clients with schizophrenia leverages interpersonal dynamics to foster recovery.
Maslow's hierarchy offers a holistic view of human motivation. Can you outline its structure and application in healthcare?
Maslow depicted needs as a pyramid, a health model, where needs are arranged in order of priority. Basic physiological needs like food, water, sleep, and shelter at the base, followed by safety and security, love and belonging, esteem, and finally, self-actualization. In practice, addressing unmet foundational needs is crucial before expecting progress in higher-level goals.
Could you illustrate how this might guide prioritization in patient care?
Certainly. If a client is homeless and hungry, mental health interventions will be less effective until those basic needs are addressed. Only then can therapy focus on self-esteem or personal growth.
Modern practice often relies on behavioral change models. How do the health belief model and Transtheoretical model inform interventions?
The health belief model suggests behavior depends on perceived risk, benefits, and barriers, explains why people may not engage in preventive health measures. Influenced by perceived susceptibility, seriousness, benefits, barriers, and efficacy. Meanwhile, the Transtheoretical model describes change as a process from pre-contemplation to maintenance. Both help tailor interventions, such as using motivational interviewing to move clients through stages of readiness.
Can you give an example of applying these models in psychiatric nursing?
Sure. When encouraging medication adherence, a nurse assesses the client's beliefs about illness and readiness to change, then uses strategies matched to their stage, like education for contemplation or direct support during action.
To conclude, how do nursing-specific theories, like Peplau's and Watson's, integrate these developmental frameworks into daily practice?
Peplau's theory centers on the therapeutic nurse-client relationship, progressing through orientation, working, and termination phases, supporting adaptation. Watson's caring theory emphasizes curative factors, actions that foster healing. Both draw from developmental and psychosocial theories to create individualized, culturally sensitive care. Cultural care theory, Leininger. Care is the essence of nursing and is culturally influenced. Self-care theory, Orem. Nursing supports activities that maintain life, health, and well-being.
So, these nursing models ensure care remains patient-centered and holistic, addressing not just symptoms but overall well-being. Are there challenges or benefits to this integrative approach?
The benefit is truly comprehensive care, but it requires ongoing education and self-reflection from practitioners. When done well, it results in better engagement, outcomes, and satisfaction for both clients and providers. Thank you, listeners, for joining us. Please like, share, and subscribe to our podcast channel, PMHN Podcast. Until next time, bye.